Welcome all. We'll be starting shortly. In the next 1 minute, we are letting attendees join the meeting. In the next 1 minute, we will be commencing. Welcome all. Welcome all to the KMA series of clinical management of COVID. Today, we are privileged to have with us Dr. Ashiono Evelyn. Dr. Ashiono Evelyn is a consultant pediatrician who is also a lecturer at the Egerton University. Dr. Ashiono has been a lecturer, has been the chief technical advisor of the Empath Plus program. The Empath Plus program is a USAID-funded HIV program in the North Rift and Western Kenya that has achieved a lot of successes in HIV management over the last many years. She has over 15 years experience in HIV management and program implementation. And she is passionate about prevention and elimination of mother-to-child transmission of HIV. Dr. Ashiono will talk to us today about HIV in the context of COVID-19. And she has put her heading as two pandemics that have collided. Dr. Ashiono, welcome and take it up.
Okay, thank you so much, Dr. Kigondo, for that very nice introduction. And thanks to all the participants for joining in this webinar, of which you're going to discuss about HIV and COVID-19, of which, as Dr. Kigondo has said, are two colliding global pandemics. We still had HIV, and now we have COVID setting in. Simon, I don't know whether we should work from your end. I don't know why suddenly it's not scrolling down. As I'm still trying to...
You had projected well. What happened?
Okay, now there we go.
All right.
Now it's working. So my presentation, we are going to go through a brief of COVID-19 among people living with HIV. Then we'll also look at the impact of COVID-19 on HIV service delivery, and that will include non-clinical effects of COVID-19 on PLHIVs, and what we can do with the information available to protect the people living with HIV. When we look at COVID-19 pandemic,
Dr. Shona, are you able to project? Are you able to project?
Share
share
screen.
On your side.
Yeah,
put on share.
Not picking up. Let me just restart, refresh. I don't know why it's not working suddenly, because...
Close the PPT and open it again, Dr.
That's exactly what I've done.
Okay, now you started you're sharing a different screen, Dr.
Yeah, the sharing is come, but now the screen,
you're
shared to Zoom.
Yeah.
Okay.
Choose the PPT as the share screen.
Yeah.
I don't know why it's not working suddenly, Peter.
You can email the...
You've opened the presentation, Dr.
Okay, is it now showing?
Yeah, now go to the first slide and put on slideshow. Yeah.
First slide and put on slideshow. Thank you.
That's okay now?
A moment. Okay, now go to the first slide, or third slide.
Yeah, that's good. That's good.
Yeah.
Okay.
Perfect. Perfect.
Okay, thank you, and sorry for that hitch. So we're looking at the COVID-19 pandemic. When you look at the most recent statistics, globally, we are currently having around 113 million cases with around 63.5 million recoveries and 2.5 that have died. When you look at specifically our country, Kenya, we have around 105 cases reported, of whom 86,378 have recovered, and we have a total of 1,839 deaths. Now, what about HIV? When you look at this other slide, you can see the concentration, which is like the light gray, not the light brown, if I may call it, or beige. Africa has not been as much affected by this pandemic in terms of the numbers, because we have around 0.01 to 10 per 100,000 in the population. And like when you look at the east and the western part, where we find more than 100, and even some cases more than 300 per 100,000 cases. What about HIV? From the recent statistics, it's also showing that it's a global pandemic, but however, when you look at Africa, the sub-Saharan Africa specifically, we have majority of the cases from these. Out of the 38 million, we have close to 20 million in the Eastern and Southern Africa. Kenya specifically, when you look at the 1990 cascade, we have around 79.5% of those people who are living with HIV identified through HIV testing and counseling, with 96% of those who've been identified as positive being on ART, and 90.6% of those on treatment having achieved viral suppression. So we can see that the 1990 goal was to be achieved by 2020. We are now in 2021, and we are not yet at the first 90, which is achieving the identification of 90% of the cases. So we have a gap of around 20% there. And then we have different models that have actually improved the treatment, having the 96% of those who've been identified being on treatment. And as a country also, we are very good in adopting the most optimized regimens for our population living with HIV. So this is specifically for the 15 to 64. When you look at the 0 to 19, we've identified 78.9% of the children and adolescents living with HIV, with 93.2% of them being on ART, which you can see is lower compared to the adults, where we have 96%. And viral suppression is where in children we are actually doing very poorly, with 67% having achieved viral suppression, and like the adults who are at around 90% viral suppression. So what are some of, when you look at COVID-19 among the PLHIVs? Some of the questions that may be asked are, is the risk of the PLHIVs being infected with COVID-19 different from that of the general population? And what is the difference? Is it higher or lower? Does the risk of SARS-CoV-2 infection among PLHIVs vary with the level of immune suppression? Those who are non-suppressed compared to those who are suppressed. And then looking also at the CD4 cutoffs, those who have a very low CD4 of 200 and below, and those who have a high CD4, is there a difference in terms of the risk for the infection? Then the other question also that comes across is being on ART protective against SARS-CoV-2 infections? I'm sure most of us have had the many theories of the different antiretrovirals that were initially thought to be good in the management of COVID. So is there any effect? Is there any protective effect of the antiretrovirals on the SARS-CoV-2 infection? And then the other thing is, if infected, are PLHIVs at risk of poor outcomes compared to the general population? Like, do they maybe have longer need for hospitalization? They have maybe poor recovery rates or increased mortality rates compared to the rest of the population? So some of these questions are what come across when you think about the co-infection between COVID and people living with HIV. So when you look at this and ask yourself, theoretically, you may quickly say that yes, PLHIVs, with the fact that some of them have very low CD4 counts and maybe very high viral loads, and the immunosuppressed status may be a risk factor for ARDS, in addition to maybe other viral infections that they may be having. And these are some of the studies that have been shown, and I'm sure the K may be able to share these slides and we see some of these that we've quoted. Then theoretically also, you can quickly say immunosuppression is not a clear risk factor for severe COVID infection. And this is from some of the observational and studies that have been done around. And then PLHIVs have an increased frequency of some of the non-risk factors associated with severe COVID-19. We know very well that some of the factors that have been associated with severe COVID-19 are age. And we look at some of the studies were done among those who are more than 50 years old in the US. Then we know very well that HIV on its own, plus the ARTs that the PLHIVs use, are a risk for cardiovascular disease and some of the pulmonary diseases, including the chronic obstructive pulmonary disease. And therefore, being at a higher risk, does it also increase their own risk associated with severe COVID disease? Theoretically, you may say yes, because they already have a risk of the non-communicable diseases and the ART, both from the ART and from the HIV itself. And then looking at the safety nets among the PLHIVs, especially in the sub-Saharan Africa, we have some of the associated factors like the poverty and marginal housing, which can actually be thought to be putting the PLHIVs who have COVID, PLHIVs more at risk. Then the other thing we could ask ourselves is, could PLHIVs have better outcomes with COVID-19? Also theoretically, and I'm sure this also came out a while ago before most studies were able to shed more light on this, it was thought that maybe, for example, some of the drugs that are being used among PLHIVs may have some protective effect and therefore have better outcomes when the PLHIVs who are on these specific drugs get COVID-19. And one of the examples that was given is tenofovir, because it has a similar structure to remdesivir, which was also initially used for treatment of COVID. And then we look at also the lopinavir, ritonavir, and the tazanavir boosted with ritonavir. Some investigations were done to see its effect, whether it has better outcomes with patients with COVID-19, but actually no benefit was demonstrated on the same. And then it was also proposed that HIV could suppress the inflammation and prevented associated hyperinflammatory state in the severe COVID-19 because of the treatment that they're already on. And then PLHIVs, just the fact that they feel that they are more at risk. I think they've been practicing better isolation and social distancing from that fear of getting infection. And therefore, it may actually be interpreted theoretically that they are having a better outcome, which is not necessarily the case. So let's look at some of the studies that have been done on incidence among PLHIVs and the clinical course. We have quite a number of studies that have been done, more than 20 studies, and specifically I'll try to relate to some done in China, Germany, Italy, Spain, UK, and the US. One of the studies that was done in South London, where they looked at 18 clients, most of them were Black, that is 17 out of the 18, and they're on long-term ART with a viral load of less than 50 copies per mil. So out of these 18, what was actually noted is that most of them were having comorbidities and then uncommunicable diseases, mostly the cardiovascular. And therefore, out of the 5 who died, out of the 18, 5 died, and 1 who was having both COVID and and HIV was still in hospital. In Madrid, we had 51, and out of them, 6 were critically ill and 2 died. And both of these were having, and the 2 were having both HIV and COVID-19. In South Bronx, we had 9 clients, 7 males and 2 females, and all these actually had comorbidities, as you can see. And out of these clients, 7 of the 9 died. And what is common among all of them is the comorbidities. Then we look at Milan, where we had 49 clients who are reviewed. And out of these 49, we had 45 out of the 47 fully recovering. That means they had a recovery rate of 96%. We look at the UK study, where we had 120 cases, and they reported around 45 deaths. And out of these also, we realized that around 30% of the total are the ones who died. So when you look at some of these studies, what do they tell us? When you look at the New York study, the same as the Germany study, as I just mentioned, most of the clients who were diagnosed to be having the increased disease that maybe led to the hospitalization and the mortalities were diagnosed to be having superimposed bacterial pneumonia, and that is like in the New York study. In the Germany study, they were having comorbidities like hypertension, chronic obstructive pulmonary disease, and diabetes, and that is what mostly contributed to them having the severe disease. And as you can see, these are the same confounders that are also found in the non-HIV population. When you look at the Spain study, we find that out of the 2 patients, out of the 5 patients who were studied, actually all of them were able to be cured after around 12 days of hospital stay. So despite being HIV positive, some of them even having a high viral load of 45,500 copies, one of them having a low CD4 of 13 cells per micromole, and one of them not having been on ART, and they got severe COVID-19 that required ICU admission. They were cured within 12 days of hospital stay. But what is important to note is that the patients who recovered also had no comorbidity. And therefore, they were at lesser risk, just like in the general population, when you have no comorbid condition ongoing. In Wuhan, we also had 174 clients who were reviewed. And out of these 174 clients, we had a population of those who are having HIV. When compared to those not infected, the only risk factor that seemed to be cutting across was the age, with those of advanced age being more at risk compared to those who are the young in age. And then the other study that was also done in Madrid, Spain, as I mentioned, in this one, after reviewing the 51 patients, it was noted that there was actually no major difference, and the outcomes were similar to both the HIV infected and the general population. One of the largest studies was done in Spain, and in this one we had around 77,590 people living with HIV who were all receiving ART, and they were diagnosed to be having COVID-19 between February and April 2020. And out of the 77,590, 151 were hospitalized, 15 admitted to ICU, and 20 passed on. And when further analysis was done among these patients from the records, it was noted that HIV did not increase the susceptibility to SARS-CoV-2 and did not increase the outcome of the severity of the COVID-19. What was actually noted, and this is just similar to the general population, that we had poorer outcomes in terms of the hospitalization, the ICU admissions, and the mortalities among the males. And you can see around 23%, the odds were around 23.4% for the admissions compared to 7.7% for females. Then the other risk was the age, with above 60 also being more at risk. And then the other thing that was noted were that those who are on FTC and TAF were actually having poorer outcomes compared to those who are on TDF. And maybe what was theorized at that moment is it's because maybe the TAF was put because the patient was having either comorbidities that had them to be switched, and therefore they were already at risk. Increase susceptibility to COVID-19, nor did it increase the incidence of severe disease. So out of these many studies, what is the key message that they're telling us about the co-infection between HIV and risk? To infection or predisposed to poor outcomes from the COVID-19. It's also important to note that the infection rates for SARS-CoV-2 among PLHIVs may not be different from the general population, as been shown from the studies that I've shared, and the key one being the large study of the Spain, where we had around 77,000 clients. Then the other thing also to note is that being on ART, whichever the class of the ART, and like where it was taught, the TDF, the PIs, may not necessarily be preventive against the SARS-CoV-2 infection. And then COVID-19 clinical course seems not relatively worse among PLHIVs, irrespective of whether you have a low viral load, a high viral load or a low CD4 count, and whether you are or you are not on ART compared to the general population. The outcomes seem to be similar between both the general population and the clients who are having HIV with the different factors that I've mentioned there. what seems to be coming out clearly among all the studies is age and presence of comorbidities is similar to the general population. And this appears to be the main risk factor for severe COVID-19 among PLHIVs. So it's not the HIV status, it is not whether you are on treatment or not, it is not about the viral load or CD4, but the age and comorbidities. And this is similar to the general population. And just because of that, we need to take note that the people living with HIV have to take the same prevention measures. And that is very key, whether they are having HIV or not, to be able to prevent COVID infection. And some of the considerations that have been made, and this one is specifically for DHHS, people with HIV who have COVID-19, they have an excellent prognosis and they should be clinically managed in the same way as people in the general population who have COVID-19. And this includes when making medical triage determinations. And therefore, the data that is available does not indicate that the disease course of COVID-19 in persons living with HIV differs from that with people without HIV. What you also need to note is that those who have comorbidities, especially cardiovascular disease and lung disease, seem to have a more increased risk for more severe illnesses, just like in the general population. And from these studies, whether it's the PIs or the NRTIs, no drug has been proven to be safe and effective for treating COVID-19. And therefore, PLHIVs should not just quickly switch drugs, maybe thinking that one will be protective or will give them better outcomes if they're using in terms of exposure and risk for COVID-19. And it's always important for PLHIVs to weigh the risks and benefits while attending their clinics when they're going to get their scheduled drugs and other interventions that they need at the facility in view of the prevention measures that are in place at that facility. What about the impact of COVID-19 on HIV? Because the initial part we are looking at now, the co-infection between the risk among HIV population in getting the COVID-19. So here we are looking at the impact of COVID-19 on HIV. We know very well, not only HIV, but most of the chronic diseases have been greatly affected by this COVID pandemic. And it's called the pandemic's hidden victims. That is the sick or dying, but not from the COVID virus, what is related to the system, because the system is overwhelmed by the COVID virus and other people who are having other chronic conditions are struggling to find treatment. And I think this is a picture that even as a country, we can easily relate to. People living with HIV and just the same effects that we experience with COVID. There are so many physical, emotional, and social well-being of factors that are threatened, both by the HIV and the COVID. But the PLHIVs are at more risk because they seem to be having already some of these underlying psychosocial and structural barriers. They have been shown to lack resilience. They may be exposed to violence, especially sexual and gender-based violence. They are feeling loneliness and stigmatized and are discriminated upon. That is still there, even up to date. They lack social support, poverty, food insecurity, and other pandemic-related stresses. They're directly facing that out of the HIV condition. Now comes in COVID, which also triples the same effects. With the poverty that comes in, people have not been going to work, job losses are there, food security coming in, housing insecurity, the medical mistrust. Some of them are not even comfortable going to the hospitals because of the lack of access to information. And then you look at some of them already being at risk with the syndemic health problems. They're at risk of everybody's at risk, just like the general population of COVID-19, unless they're taking in the preventive measures. They're already HIV positive. They're at risk of non-communicable diseases, and some of them are already having the non-communicable diseases, STIs, other co-infections like TB, malnutrition, mental health, and substance abuse. So these are some of the real threats that we come across day to day So some of these effects actually are directly impacting on the outcomes of the HIV clients. Some of them are fearful of getting COVID-19 themselves, and therefore they don't go for their clinic appointments. And you know very well that may affect the adherence and subsequent viral suppression. They are worried about their friends, their family, their loved ones getting COVID-19. They are actually confused about where to get the accurate information. I'm sure there's a lot of myths going around about COVID-19. So that confuses them. Frustrations, and this happens both even in the HIV and non-HIV, both the clients and even the healthcare workers. Anxiety, alcohol use has increased, financial challenges. Because of the poverty and the food insecurity, some of them are skipping meals, and not forgetting that some of the drugs that are in use, you need at least to take with a meal. So you can find that skipping meals, and if at all the specific regimen they're using, they need to take with a meal, then you can see the impact of that. Then reported missing the HIV medication, either because they didn't get to the facility or because of the meals, as I've mentioned. And then generally just being disoriented and being more forgetful. And a number of these have actually, some anecdotal studies have been done, like in Uganda, where women fearing of food shortages makes it a deadly mix between HIV and coronavirus. So what are the key considerations? You look at the supply side in HIV. So on the supply side, there is the risk of the SARS-CoV-2 transmission in crowded settings, including in health facilities. We know very well some of our comprehensive care centers, we normally have very long queues, and unless that is well managed, it's actually a risk in transmission. Then there is movement restriction, though it's really, right now it's a bit relaxed, but we really had some initial very strict movement restrictions as part of the control measures. And these prevented access either of the providers to the health services or the clients themselves reaching the facilities. Then some of the facilities were either fully or partially closed. Number one, some of them were converted to COVID centers, and some of them, maybe because of one reason or another, the healthcare workers, they were forced to have either full or partial closure. And then initially also, there were some threats reported to HIV funding. When you look at the demand side, fear of accessing health facilities by the clients, movement restrictions, and income loss as a result of COVID-19 actually impacted on uptake of the services by the clients. So specific actions had to be taken so that you don't lose the gains that had been made over more than 30 years in terms of containing HIV. And some of the studies that have been done have actually shown that unless a concerted effort is made, these many gains are going to be lost because of the different factors I've talked about on the demand and supply side. And actually some of the modeling that was done was even trying to give a picture that if these factors are not really going to be looked at and addressed properly, we're going to have an increase, because we had already gone down to around 470,000 AIDS-related deaths by 2018. And from modeling, this had been seen like it's going to go back up to around 1 million. Fortunately, this did not happen because of the some of the mitigation strategies that were that came. So one of the things also that was thought of was a potential shortage of the ARVs, especially looking at the lopinavir, ritonavir, because of what was thought that it's going to treat. It was part of the treatment for coronavirus. And actually some of the countries even were fearful and stopped exporting the PIs in the name of maybe they're preserving them and manufacturing them for their own use in case they're actually proved to be safe and efficacious in treating coronavirus. Looking at the studies that were done, like the Solidarity clinical trial, whose results were recently released by WHO, we can see that some of these drugs actually have been shown to have little or no effect at all on COVID-19. and therefore it indicated that mortality, initiation of ventilation, and duration of hospitalization was not at all affected by the use of these PIs. And that actually is one of the ways that the country, both the country and the global world, is trying to make sure that the clients, the HIV clients, are getting their drugs, and there is correct management protocols for people having COVID-19. So we'll specifically also just look at the different impacts, the testing, the treatment, and the prevention. When you look at the testing, this is data shared from NASCOP, where we looked at from January to June 2020, what exactly happened. Because we know very well when we talked about the demand and the supply side, either the health facilities were closed or the clients were not comfortable coming to the facilities. So for sure, it affected the workloads in the different facility. So when you look at the pre-COVID months, that is around January, February, there was some drop in terms of testing, but it was just within 10%. However, by April, comparing March to April, there was actually a big dip of around 32%. And this, remember, is when now many measures were coming in, and the COVID scare was actually at its peak. And this contributed to, you can see the big dip of from 52,571 clients being tested. And this data is from KHIS, so that is from all the facilities across the country. We had 14,839 being tested in April. So you can see the big dip. However, from May and June, you can see the tests started going up again. And in the next few slides, you're going to see what exactly was the role of NASCOP in ensuring that this dip does not continue, and quickly putting in mitigation measures to have clients access the services as they needed. We know very well a number of facilities, the clients stopped going there in the fear of COVID, and at the same time, the movement restrictions hampered the uptake of services and the health-seeking behavior. So in the same period, you can see the identification was reduced, but the linkage actually was good. So among those who identified to be HIV positive, all of them were able to be linked, and that was a good, above 90% of them were able to be linked. Similar picture was shown in the US, in the Boston, where HIV testing also really dropped, and same to the PrEP care. When you look at PrEP in our country, we had a dip in April, just after the initial case was announced in March, and we had 2,755 initiating PrEP in March, but by April we had a drop to 1,974 from these facilities that were sampled. But then in May and June, the trend came back, at least normalizing. And what we can say about these, and even when you look at the current on PrEP, is once healthcare workers are able to identify the risk of those who are in need of PrEP, at least they're able to initiate them and follow them up through the measures that were put in place to make sure that they are getting their treatment, their prophylaxis as needed. The drop in current on treatment, you can see the current on treatment across from January, there was a steady rise up to May. Then in June, there was a sudden dip. And noting that some of the clients, actually majority of the clients who are stable, they're issued with around 3 months treatment. So maybe this March effect was not the March dip and April dip as seen in testing and in PrEP, was not felt in in the current on treatment, because most of these clients may be already having refills from the previous month. But what about these? You can see now from April, May, the number newly enrolled on treatment. When you look at the number newly enrolled on treatment, it actually went hand in hand with the number of positives identified. You can see the green line. Number one, the number of positives identified went down because of the low client turnout and therefore low identification, but the linkage was good. So you expected the TX CAR, the number on treatment, to go up. But the fact that it didn't go up showed that there was a problem somewhere in terms of retention. That means those who are being initiated were actually joining into the fold, but among those who are expected to be coming the TX current were not coming. And that is what may have contributed to the June data going low. Though we also can't rule out data issues, knowing that maybe some of the facilities, for one reason or another, may have been closed, or some clients were getting treatment from the nearby facilities, which may not necessarily be where they're enrolled, and that contributed to the data going down. So that is something that still needs further interrogation. In March, once the COVID pandemic was declared by the president, the NASCO put in measures, and working with the USAID and CDC, were able to quickly pick up with the implementing partners to making sure we are following the guidance as released by NASCO. So NASCO tried to put in measures both in terms of the testing of clients' identification, in terms of ART continuity, and in terms of viral load uptake and suppression, and mothers' PMTCT prevention. So when you look at this guidance, for example, NASCO encouraged that all clients, irrespective of the duration they've been on treatment and other underlying factors like maybe pregnancy, the age, and viral suppression status, all to get 3 months refills. And just by having the 3 months refills, you can see the effect it had. This slide, the charts on the left are from the AMPATH program, where you can see the TX curve continuously went up. And this is because of these measures that were put in place. Out from this circular that was shared by NASCOP, clients were able to get the 3 to 6 months refills and being fast-tracked at the facility, so that upon triaging and screening and making sure that they are not having any risk for COVID or having any suspicion as a suspect for COVID, they are quickly fast-tracked to get the services they need. And those who are also stable were encouraged to get the drugs from the community. And this enabled the HIV program, both nationally and through the implementing partners, to be able to continue providing quality services to the clients. And from this, you can see, we had quite an increase in the number of clients being fast-tracked at the facility. And those who are being fast-tracked, just a reminder to all of us, are those who are stable. They have no OI, opportunistic infection concurrently at that moment. They are virally suppressed and were not pregnant or breastfeeding. So they are quickly fast-tracked through the services. They are able to get their drugs and go home. At the same time, they're encouraged to get their drugs from the community. And you can see that the number of clients who are actually getting the drugs from the community almost remained the same by June, but later there was some increases from the program data that we saw from AMPATH. And this is related to the guidance that is being given, that was given out. And at the same time, the intensive work done by the implementing partners in recalling all the HIV clients, just allaying the fears that they had and reassuring them of the services. And at the same time, picking up some of the models of delivering of the drugs at the community level, and having healthcare workers or the peer support leader coming up to pick the drugs for them. So to ensure that there's continuity of prevention of services during COVID, partners came up with very innovative strategies, both for the commodities in ensuring that they're getting them. So we had borders delivering commodities to the community, and even samples from within one facility to another. Healthcare workers strengthened virtual engagement and outreach with the client. So it's not only medics or healthcare workers who strengthen their CMEs and webinars, but also just reaching out to the clients. Actually, virtual engagement has been shown to have given better results during this period. And then some of the areas where we identified the need for support of the PPEs and all that, were able to support the same. And scale up of distribution of HIV self-test kits among the community was also greatly strengthened. Away from that, what do we have to say about COVID-19 and vaccines? COVID-19 vaccines and HIV. There is no difference, and people living with HIV can get the COVID-19 vaccine just like the rest of the population. So working with available information to protect the PLHIVs, the key consideration is that although there is a lot that is being learned from COVID-19 and HIV, there is sufficient information that policymakers can use, and these should be able to update the practices and the strategies that you are working to ensure that PLHIVs are not being affected greatly because of this COVID pandemic. So we need to tailor our support to make sure that both the clients and the providers are not overwhelmed and they're not going through this stressful period in a way that is going to further exacerbate their stress. So the providers need to stay updated through trainings, which can be done virtually, online, or webinars. Then we need to have enhanced communication with the clients, and this can be done through teleconsultations. You don't always have to be telling clients to come to the clinic. What we've seen, the DSD and multi-month scripting, because we've seen once NASCOP released that circular, actually it was able to improve the number of clients accessing treatment and be able to quickly counter the dip that had been seen in June of the clients on treatment going down. Then the other model that can also be used is the advanced decentralized drug distribution, whereby the drugs are distributed up to the nearest community pharmacy, something that is still in the pilot stages in Kenya that can be adopted. Then we need to focus on ensuring retention of clients in care. That is one of the core things providers always need to do. And just by routinely checking out who is supposed to come to the clinic, reaching out to them via SMSs, via telephone calls, and being able to make sure they're on treatment. And those who are stable can even be delivered for drugs at home. And then using data for decision making at any one time up to the lowermost level. We always don't need to wait for the national to share the data for us to use, but just inculcating the culture of data use right at the facility level, and practicing IPC and taking care of the mental health of the healthcare workers. And I'm happy KMA has actually prioritized mental health for healthcare workers all along, and I'm sure this is having a very good impact on continuity of services. What about the PLHIVs? They need to maintain adequate stock of ARVs at all times, and if they're having any other concomitant medications that they're using, they need to have it at any one time in good stocks. And then they need to stay in touch with the providers for accurate information and not just following any myths that come across. So you need to empower them in case they have any question, let them reach out to the healthcare workers to get the correct information so that they're not misinformed. Outside the end, it may lead to unwanted outcomes. Then they need to learn to discuss with their providers all the services that are, the options that are available for them to get the services so that those who are stable can comfortably get the treatment from the community. Then they need to stay active while observing the guidelines for social distancing, hand washing, and other non-pharmaceutical interventions like masking. They need to understand that there is need for ART continuation, even if they have been diagnosed with COVID and self-isolating at home. They need still to continue taking their antiretroviral treatment. And then they need to follow any other guidance that is coming out, either from the government directly, from the county government, from the national government, or from NASCOP. Then one thing that also has been learned from this COVID-19 and the HIV pandemic, we realized that actually there's a lot of investments and infrastructure that have been put across in the HIV sector, both nationally and globally. And this is one area that actually the COVID-19 responses can greatly leverage on. We have the potential to build on this infrastructure, the research that has gone on HIV, the policies that have been done on HIV, just to learn from them, and just leveraging on some of the capacities that have been set up already, like the information systems, the supply chain mechanisms, the lab networkings, and even the strong political leadership for HIV. You can see, like, for example, in the country, we have NASCOP that has been strongly and consistent to making sure that they're driving a scientific evidence program. And this also I can see is what is taking place in the COVID world, where we are having every other time the guidance changing and information coming out that is helping in us making the data-driven and scientific-driven decisions. So some of the areas that can be able to be leveraged on, and learning that these two are actually almost the same. When you look at HIV, for example, in identification, in HIV, we have the provider-initiated testing and counseling, and we have the voluntary counseling and testing, which is almost what is happening in COVID, where we have the testing of healthcare workers, testing of people presenting at points of entry, and testing of symptomatic patients. So it's actually almost borrowing the same leaf. Then containing spread through contact tracing methods. I'm sure we all know that in HIV, we always prioritize testing of the biological children and sexual contacts, that is the index testing. And we look also at some of the high risk areas where the co-infection of HIV may also be high, like the TB co-infected and there's the STI clients. And in the same way, we are doing that so that we can increase the yield and make sure that those who are there, who are identified, they are able to get the necessary interventions to contain the transmission of this infection. So in the same manner, for COVID-19, we are also doing contact tracing and testing of the non-contacts so that we are trying to contain the infection and isolating those who are identified and giving them the necessary treatment that is needed. Rapid provision of package of interventions also, it's similar to both of them. And in both of them, we see where there's that one-on-one follow-up of the clients to make sure that actually they are doing what is stipulated in the guidelines and in the different protocols that have been set, including the home visits and the calls and following up to make sure if they're having any other comorbidities, they are quickly managed. When you look at the laboratory and supply chain platforms, you can see in COVID, as soon as we had the cases, we used to have the main lab hubs where samples were being tested either in Nairobi, Kisumu, Eldoret, or Mombasa. And that is the same thing that the HIV lab networking for viral load and EID. It's working on the same principle. So just building on that, we can be able to leverage learning from the HIV lessons to build what can work best for COVID. And the same in strategic information. You know very well that in HIV, we are able to use the data at any one time, granular data that is reviewed, some even on daily, weekly, and monthly basis closely, and that is used to make decisions, not just at facility level, but all the way up to the national level. And you can see that is what has been replicated in the COVID, the situation room or the situation reports that are being released every other day. So there are a lot of similarities, and this is one way that management of COVID and the policymakers and the whole team that is working on making sure that you're containing this pandemic from the national, global, national, county, sub-county, and even facility level. There is a lot that you can learn from the HIV programming and be able to contain this the COVID pandemic, while at the same time ensuring that the gains made in HIV over the years are not lost. So what are some of the closing thoughts? There is need for local data and continued vigilance, especially in terms of the COVID-19. Communication is very key. We need to continue having innovations in service delivery. And I'm sure this is one thing that even as our healthcare workers, you can say maybe is a plus, is that we now know that we can actually be able to manage clients at the comfort of their homes instead of them coming and crowding in the facilities at every other time. And from the HIV perspective, the differentiated service delivery and multi-month scripting are some of the innovations that have shown to be very, very helpful and giving very good results. And then just as I've mentioned, lessons from the HIV response can be taken upon and replicated in the COVID response. So I'd like to acknowledge NASCOP and USAID because AMPATH is USAID funded, NASCOP for the contribution towards this presentation, Professor Sylvester Kimayo, who is the Chief of Party for AMPATH Plus, Dr. Lazarus Momanyi for his contribution, and Violet Oramisi and Christopher Komen, and not forgetting KMA for this opportunity to present. Thank you.
Thank you very much, Dr. Shiono, for that presentation. And I did not warn my viewers that given a chance, you can talk for about 3 days on this issue of HIV and COVID. I want to thank you. Some of the lessons I've taken home from HIV in relation to COVID is that they are very similar because they are both pandemics. We needed to identify symptoms at risk, individuals, contain the spread through contact tracing methods, rapid provision of interventions. We needed clinical lab and supply chain platforms and strategic information. And thank you very much for your advice that we need to use our local data, and we have to have continued vigilance and communications and innovation in service delivery. And now, in a short while, I think we'll be closing. I would like to recognize the presence of the Vice President of Kenya Medical Association, Dr. Otara, who is among the panelists. I would also like to recognize Nyandika of the National Nurses Association of Kenya, is the project coordinator. And I would like to recognize all those who are tuned in all the way from Garissa, Machakos, Nairobi, Bungoma, and Nyamira. Evidently, devolution is here at the Kenya Medical Association and other professional association websites. Maybe I would like you to take 3 questions before we come closing. And the first one comes from the vaccinologist specialist, Dr. Ombeva, who asks, is HIV protective against the severe COVID, especially the risk of cytokine storm? Doctor, you can take that?
Okay, thank you so much for that question, Dr. Ombeva. And I think in one of my slides earlier on, if you saw, that is one of the things that was thought, HIV being protective against the cytokine storm. From the studies that have been shared, the cytokine storm is not protective against severe COVID. Thank you.
Thank you again. The next question is that, and a very important at that, is there any relation between COVID-19 and false positive HIV tests? Is there any relationship between COVID-19 and a false positive HIV tests?
Okay, remember, hello?
Yes, Dr. Shio.
Yeah, the two of the COVID-19 test does not in any way affect the outcome of the HIV screening test. The HIV test that you are using, that is the determined and confirmed by the first response, are actually very specific, and the sensitivity is so high. Sensitivity and specificity is over 99%, and therefore there is no relation between the recent COVID infection and the HIV screening test. Thank you.
The next question is, do antiretrovirals offer protection against infection from COVID? That's another question that has come.
Okay, thank you for the question. Remember, just as I mentioned at the beginning of the presentation, initially it was thought that some of the antiretrovirals like the TDF and the PIs, specifically lopinavir, ritonavir, were protective against the infection. But after the studies that were done, it's been shown that actually they're not protective, and they still, even the studies that had been done about trying to use them for the treatment, especially the lopinavir, ritonavir, have shown no much efficacy in terms of being able to treat COVID. So there is no difference. Don't switch treatment in the thought of that may be some antiretroviral protective. It is not protective, as per the studies that have been shared, including the latest one, the Solidarity study from WHO. Thank you.
Yes, I think you covered this, but someone wants clarification about COVID vaccination and people living with HIV/AIDS. Dr. Shiono, what's your comment on vaccination of people living with HIV and AIDS and COVID vaccination?
Okay, so as I mentioned earlier, the people living with HIV, there is no effect, no negative effect of the vaccination, and therefore, just like the general population, they should be able to get the vaccine. And I think as a country, there's a prioritized healthcare workers, and then before moving to the general community. So any person having HIV, there's no contraindication to getting the COVID-19 vaccine. The same applies. What is similar in the general population is also what applies to the HIV positive clients. Thank you.
Oh, thank you very much. Dr. Shadrach Kipruto made a comment that he thought all immunosuppressive states increase the risk of severe COVID disease. And I think you covered that, but maybe you could make a comment.
Yeah, I'll just add on that. Unless now the patient is having the comorbidities that you've talked about and is at risk because of the age. Otherwise, from the studies that have been done, like you saw in Germany, then in Madrid, it was shown actually there was no increased risk if you're not having any other comorbid and you are not above 60 years old.
Thank you very much. And the last question here is, it's actually not a comment. Jonah Kipngetich has actually said that the topic is very well researched, and I think he has appreciated it. And yeah, we have come to the 15:05 mark, and we like this session to take exactly 1 hour. I would like the program officer, Nyandika of National Nurses Association, to say something before I close the meeting.
Thank you, Daktari. And also thank you for that good presentation. Okay, I joined late and I'm sure I missed a lot, but what I'm taking home is we've had really a good response in HIV during the COVID pandemic, and we've learned from HIV programming on how to tackle COVID, and especially adherence to drugs and the benefits of ensuring that our clients adhere to drugs. So I would like to thank the panelists and members for taking the time to join. Thank you, Daktari.
Thank you very much. I have seen a lot of comments. The CPD points are generally sent to the email that you register with. I have seen a lot of people asking whether the CME is on the PPB portal. Peter Ogero, the IT technician of IT officer of Kenya Medical Association, will look into that. And I've seen a lot of pharmaceutical technologies in the presentations. And I can assure you we are together. And actually next week, the Pharmaceutical Society of Kenya, which is the association that is representing the pharmaceutical technologies, are actually taking the clinical COVID-19 webinar. And we will be hearing what they have to present. As Dr. Shoya has mentioned, on Tuesday, 7 to 8:30 p.m., we have the psychological webinars, which are open to all. And all Thursdays, 2 to 3, we have the COVID-19 webinars.
Simon.
Yes, Ashia.
Doc,
yes.
There is a doctor who wants to speak kidogo. Dr. Shiona, please kindly go on. Introduce him or her. Yeah.
I was saying, kindly, if we can allow NASCO, I'm sure there is 1 or 2 NASCO representatives. I don't know that Dr. Laz Momanyi.
Oh, Momanyi is there, yes. I had seen him in the Momanyi, can you please say something? Hear you. Is Dr. Momanyi speaking? Peter, is Dr. Momanyi able to?
No, we still can't get you.
Dr. Shiono? Dr. Momanyi doesn't seem to be able to, he's saying no audio.
Daktari.
I think, Peter, can you upgrade him?
We still cannot hear you.
Maybe you unmute him.
Peter, kindly upgrade him.
No audio, Doc.
Unfortunately, we are unable to hear Dr. Momanyi.
Nothing still, Daktari. Can't
I
hear
think
you.
it's on his side, Dr. Shiono. I think it's on his side.
Oh, it's on my side. Sorry. Yeah.
Okay,
sorry
Dr.
about that.
Momanyi.
Yeah.
Dr. Momanyi?
Hello?
Yes.
Dr. Momanyi is giving his apologies. He can't be able to get through.
That is fine. I think we'll give him another opportunity later. But thank you very much, Dr. Shiono. That was a fantastic presentation, and you did not disappoint. And I think we will continue meeting and giving more presentations on this very important topic that almost got forgotten because of COVID-19. And with that, I want to bring the meeting to a close, and we will see you in the next webinar. Thank you very much.
Right, thanks.
Thank you. Bye.
Thank you, Dr. Otara, for visiting.